welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of Kevin MD. Today in the show, we have Joe Nicholson. He is a family physician and healthcare executive. He wrote the Kevin MD article, "It is time to make a dent into social determinants of health." Joe, welcome to the show.
Yes, sir. Yeah, thanks for having me, Kevin. It's really a pleasure to be here.
So we'll get into your article in a little bit, but first off, can you share your story and journey to where you are today?
Yeah, sure. So I've got a bit of an eclectic path. I'm an old Army doc, chief of emergency medicine a lifetime ago. After that, I went to private practice actually for about 7 years and then wound up becoming a Blues executive, chief medical officer of a Blue plan there for 8 years. And then I was recruited into a kind of an interesting moment with a national specialty hospital system who is really trying to make the transformation from out-of-network to in-network PPO participating institution. And through that, I really wound up becoming like their value-based care guy, bolting in value-based care elements into all of their contracts. Was there for just short of a decade. And now for the last, coming up on 3 years, I've been with Care Allies. And Care Allies, I don't know if you know them in the parlance, right? They call them an MSO, which means nothing to almost anyone, but we're both an energizer and facilitator of value-based care for physician practices across the nation. Operate in about 10 states, about 500,000 patients under the hood. And we help our physician partners just hit the cover off the ball for all of their value-based expected arrangements with any payers that they have them.
So you spent a lot of your career on the insurance side of medicine. And for a lot of physicians, that's a little bit of a black box. So now that you had experience on both sides, the clinical and the insurance side, what are some misconceptions about the insurance side that you want physicians to know about or clear up?
Yeah, well, so, it's a great question. And thank you for that. You know what I would say first and foremost on the insurance side in particular is they are genuinely trying to help. Right. And I would also say you would find almost every major health insurance company I know of willing to partner. Right. So if you've got an axe to grind or something that's not working out for you, reach out to the local senior executives at that health plan and engage in a dialogue, because I think you would be pleasantly surprised that they are hungry for that kind of collaboration and input.
And if physicians ever want to transition outside of clinical medicine and say work on the insurance side or do something similar to what you're doing on the non-clinical side, what's some piece of advice that you could share with these clinicians who are interested in making such a transition?
Another great question, Kevin, because I actually get that one probably more often than just about any other single question from my clinician colleagues. And in short, if you're interested in sort of that executive physician path, now, again, I've done it on both the hospital system side as well as on the insurance side. If you're interested in the insurance industry, I think your best point of entry there is to get yourself engaged with committee work at your local insurance carrier of choice. But once you get involved in that committee work, then you'll begin to see the intermachinations, you'll develop relationships. And like so much of business, it's relationship, and how well can you help them carry the ball and meet their own objectives.
So how difficult is it to make that transition away from clinical medicine into the executive side? Because as you know, we don't get a lot of that training in residency and medical school.
Yeah.
Just from your experience with other physicians, how difficult is it for them to make that transition?
Yeah, I would say that's a very individual journey. And for me, it was a difficult transition. It was hard for me to let go of. And in the interesting moment, when I came on to Blue Cross initially as a medical director of medical services, one of the things I negotiated prior to joining was I wanted to continue working emergency medicine or as a hospitalist every other weekend, which I did actually for a number of years until I became CMO. But so I sort of bridged my time by continuing. And then I know a few of my colleagues that are still on the insurance side of the equation, they'll continue to this in different ways. They'll either donate their time for a local nonprofit, or they will help at, university center, help the less fortunate, and really just donating their time. But I think keeping your hand in it is one clear way to help yourself make that transition.
All right, let's transition to the Kevin MD article that you wrote. It's titled, "It's time to make a dent into social determinants of health." Now, for those who didn't get a chance to read your article, can you just walk my audience through it and share the story of why you decided to write it?
Yeah, so the why is probably really centered around just my passion around SDOH and closing that gap. It's something that is often talked about. I think it's getting more airtime in the last maybe 3-5 years, Kevin, than in my lifetime. But there's not a lot of people doing stuff. And so, part of what I try to take the opportunity every time I'm blessed to have the mic or a pen in a platform is to encourage people to start where they're at and just get involved, right? I think everyone needs an oar in the water in this. The solution, it's a macro, highly complicated solution. It's not a simple solution, or we would have solved it already. And in the article, I just kind of walk through some of those challenges. I've got a call to action in there as well. And then I've got this crazy idea that I've been trying to press the action for that I think could act as an accelerant to the solution on the national stage. We'll get to that in a little bit if you like.
Yeah, sure. So why don't we zoom in? Talk to me about, first off, your interpretation of what social determinants of health is and some concrete examples of what you're talking about.
Yeah, no, that's great because it can feel a little amorphous, I think, to the audience sometimes. But let me start with the zip code dialogue, because this is really, Kevin, where my interest in the beginning became peaked. Is probably almost 20 years ago. There was an article published by a doc at Oklahoma University, right in my home state here. And it highlighted the differences in life expectancy based on zip code. And I was floored by that. So, here I am at the time. I can't remember if I was still in private practice or if I was the blues by that time, but, I'm blessed to have a great lifestyle. I live in a very comfortable bubble in South Tulsa in an affluent community. But guess what, right? That's not true for everybody in Tulsa Metro. And I was just really taken aback at there's literally a difference in life expectancy. And it was a big difference. It was like 15 years or something, just staggering. And that was my first sort of peek into, what's going on here. And at first, right, we always personalize things, but I thought, man, this is a real Tulsa problem. And then as I really got into it, it's like, oh, this is it's an American problem, like almost every major metro area that you'd want to name. And so back to what is SDOH, right? It are these disparities that separate, in this case, I'll think about my patients, but they're the disparities that separate my patient from healthcare they could or should or otherwise would receive. And maybe it's a financial issue. Maybe they're having to choose between paying their electric bill and getting the medications that they need. Maybe they've got some mental health issue that's incompletely or entirely unaddressed. But it's all of these different elements that represent a chasm between the patient and the treatment that they need. And in the interesting moment, and now there are quite a few studies published on this, but and a humbling moment, Kevin, for guys like you and me in the business, the work that we do inside of just pure clinical medicine, honestly, has less of an impact on health and life expectancy than these social determinant pieces, right? But probably by orders of magnitude, but more than 1x for sure. And it's a humbling moment. But that's what social determinants of health is. Part of it, I think, is just a simple awareness piece. And then some of it is as you delve into the different elements. And they're typically named like, 7 or 8 different elements of SDOH, and transportation would be like another one. But all of these different elements can have an impact, and then we're looking for ways to bridge the impact. And the other thing, just on my short wrap specific to social determinants of health, that sometimes just sort of gets lost in the sea of dialogue in SDOH is the importance of community-based organizations and bridging that gap.
Sure.
Right. And just think about your local nonprofits. They could be faith-based or not, but it's these nonprofits in your community that are trying to help a segment of society inside the community in which you live. It could be a food bank, right? It could be a geriatric center. It could be an Alzheimer's group, right? You name it. But most of the heavy lifting is done by these CBOs or community-based organizations in your community. And so the solution in my mind, and I think that's why it's been so difficult to tackle, is no single entity can solve it.
Yeah.
I mean, the government can't solve it by themselves. Docs like you and me can't solve it by ourselves. The CBOs, right, are trying, but they can't do it by themselves. And it really takes a true community lens, community effort. We need to think differently around our solutioning for SDOH. So sorry to go long, but that's my point of view there.
Yeah. So why don't we go into more details? So if we were to bridge those gaps and try to solve some of these problems that you bring up, you mentioned that, things like CBOs, a little bit patchwork, there's no centralized organization that can improve things. So what will be your approach to help close some of these social determinants of health?
Well, so I'll go at this in 2 different ways. First, in the micro, I would say start where you are, make a difference in your own community. And then, to kind of go to the next bubble in the organization in which you are. So I'm inside of Care Allies. We started with a pilot. We now have a full-on SDOH program with social workers and pharmacists, nurses that help connect the patients with the physician groups that we serve to CBOs to close their gaps, or maybe we're connecting them to their insurance carrier if they can help close that gap. But starting where you are, either in your organization or personally, make a difference. My crazy idea would maybe just that, right? Maybe, Kevin, it's a banana sandwich of an idea. But the fundamental difficulty I see with so many CBOs is I think, to use your phrase, it's like a patchwork quilt of organizations. They're not connected with each other. And unless they are somehow connected with one of the emerging, these, I call them CBO aggregators, right? These vendors that manage CBOH, and they pull them into some version of a platform, which I think is a baby step towards where I'd like to go. The gap is so many of these, it's run by volunteers, and so much of their work winds up being managed on Excel spreadsheets, or worst case scenario, stubby number 2 pencil and paper.
Sure.
And so the big idea would be, could we create a paradigm on a national level, right, from a policy perspective, that every healthcare oriented or SDOH oriented nonprofit in the nation would get free, no cost access to a platform that does that aggregation, and almost think about like a HIE, Health Information Exchange connector. But if we could connect them all in a real way, using some version of, it'd have to be HIPAA compliant, but open source data where anyone who's trying to help that community could tie into that data, see what the gaps are, and help from their own lens understand how they could help that community that's underserved. So anyway, that's the idea. But I think it would be at least an accelerant to SDOH solutioning if we had some national platform that could connect them, that they could adopt at no charge, basically.
Can you give examples of what individual physicians have done in the past? A story that you could tell, or a case study that can maybe move the needle a little bit from an individual level in terms of closing these gaps?
Think about our own SDOH program at Care Allies. It really was the brainchild of one doc that we work with in deep South Texas. And I won't name him, but I should, because he's just such a swell guy. But they literally are supporting patients in some of the poorest zip codes in the nation and along the Rio Grande Valley. And they have, just a ton of SDOH gaps for the community they serve. And they reached out to us and said, hey, can we do something about this? And so, working collaboratively with that physician group, we've created from nothing something that started with getting a couple of social workers to begin to focus on some of those SDOH gaps. In the earliest days, we were doing something as simple as referrals coming out of that group, where the physicians themselves were identifying needs, and then they would pitch it to our team to help try to close that gap on behalf of the member. And that's an example of really starting from nothing and creating something that today is now blown into a program that's operating in 3 geographies. I think we have 2 more expansion geographies for this year. But it's meaningful. And let me give you a patient-specific example that might be an interesting moment for your audience. So this was a case that I think was referred into our team. We had a patient who had shown up, and I'm making up these numbers because I don't remember them exactly, but she had been to the emergency room something like, it was a crazy number of times. It was like over 200 times in the last year. And it's like, what is going on? And then a number of those had resulted in admissions. And come to find out, it was really the driver for that was an anxiety-driven moment where her husband, the father in this particular family, had died. And it wasn't a pretty moment, right? Kind of in healthcare, just the way the whole death went down, the entire family was there and kind of saw this thing unfold. So not just the mom had anxiety, but the children had anxiety. And every time mom had the smallest amount of indigestion or whatever, that we're not going to do the dad thing again, right? We're calling 911. We're going to get an ambulance. And once we got mental health services engaged and the primary care docs engaged in supporting the anxiety and some counseling for the family unit, all of that dropped to almost zero over the next 6 months. But, it's an example in that case, what was probably an unaddressed mental health concern, anxiety, that really was driving, and in the interesting moment, driving cost, right? Not just services, utilization, and time and energy, but driving total cost of care delivery up. And it was really solved just with some, cogent handholding and some mental health support.
We're talking to Joe Nicholson. He's a physician and healthcare executive, wrote the Kevin MD article. It is time to make a dent in social determinants of health. Joe, what do you see as the future in terms of your path, in terms of closing some of these gaps? What do you see in the next year or two?
Well, if there was any good thing that came out of this pandemic, it was a real focus, I think, nationally on social determinants of health and how that gap is widened. And we know historically that any crisis widens that gulf. And then, as if things weren't bad enough in the pandemic, now you've got this crazy hyperinflation. So now we have a whole new tranche of people who were doing fine, maybe last month, paying their bills and getting their gas and, now going back to work physically. And all of a sudden, right, now they're having to choose between their medication and their, heating bill and so on. But the reason I highlight that is that chasm, I think, has at least created a national spotlight. I would like to think over the next 2-3 years that we're going to see at a national level some continued acceleration around social determinants of health. Even CMS, I don't know if you clocked that headline, we do participate in the DCE, that direct contracting entity. It's that alternative payment model out of CMS. They've now rebranded that ACO REACH, but it's ACO REACH for a reason, because it really has an emphasis on addressing social determinants of health. So I think we're going to see more and more organized interest in and hopefully rewards for people who take an active interest in closing those gaps on a national level. Specific to Care Allies, again, we've got 2 expansion markets for SDOH this year. I'd love to have 3 or 4 more for 2023.
And my final question, your take-home messages to the Kevin MD audience.
Take-home message, SDOH, get involved, right? This is not something that can be solved without really the most of us being involved. And so whether it's engaging with a local nonprofit, whether it's helping organize something inside of your local company, I would just say, get out there, get involved, create something. Let's talk less about SDOH and do more.
Joe, thank you so much for sharing your time and insight. Thanks again for being on the show.
Kevin, what a treat. Thank you so much for having me. It was a pleasure to be here. Thank you so much.